So good morning, everyone. As Dr. Weiner was alluding to, my name is Kevin Dixon. I'm the president and founder of Katie Consulting and Lifeline Intervention. I started this company about 3 years ago because what I found in 15 years in the industry of building treatment centers and intervention companies was kind of a gap between family, companies, treatment centers, and the people they deal with when we talk about interventions. And so today we're going to be covering a few topics about that. But that's really why I started it, was because that's what I saw. Today we're going to be talking about the Johnson model intervention process. And there's several different types of interventions. There's the systemic, invitational, the Gorski model, Dr. Vernon Johnson's model. And I personally believe that the Johnson model is really the most successful because it takes really the best from each one of those different modalities of intervention and really creates a success to really get the patient into treatment. The Johnson model intervention process is where family and friends are directed by the professional interventionist on how to communicate effectively excuse me, to the individual versus the disease of addiction. Because the person, the individual patient, has anger, denial, placating, manipulating, guilt, shame, remorse. And employers, families, they have one tool, and it's love, and it's not enough. So that's why this process is really so successful, because you are talking to the individual versus some of those dysfunctional and destructive tools that the individual has. New versus old intervention models. Showing compassion rather than confrontation, no judgment, or judgment versus blame and verbal attacking. One of the other things I want to touch on is importance of the process of intervention, kind of the ABCs, if you will. When is an intervention needed? I'm going to give you a couple scenarios, and maybe in your line of work and what you guys do, maybe you've come across these, or maybe not. So an employee has a loved one with a substance abuse problem. If the employee has a loved one suffering from alcoholism or drug abuse of any other addictive disorder, the employee can reach out to the EAP to address the situation by referring an interventionist. The employee is having a hard time helping the family member, and it is making it difficult for the employee to concentrate at work because the home situation with their loved one with the disease of addiction. The employee reaches out to the EAP, which can help provide solutions such as an interventionist if the patient is unwilling to enter into treatment. Yesterday I had the privilege of sitting in and just kind of hearing a little bit of what you guys see, what you guys feel, and someone was mentioning about an employee that they had, and it was really they were trying to get him into treatment, and the employee was kind of bartering. Can I do an outpatient? Can I, do I have to? And I really feel that the more you get educated, the more you understand, the intervention process as a tool for you, it can kind of help alleviate that. Versus kind of the big brother, so to speak, airline, ABC airline, the EAP, you guys, ground zero, and saying, yeah, you have to do this, and throwing that leverage, so to speak, you can kind of a gentler, softer way. Step back and maybe refer the family to an interventionist, the employee. Perhaps maybe we could bring an interventionist in. As Dr. Weiner was alluding to, I've found in 15 years that it's wonderful that the word intervention is becoming so prevalent in our society. It is a great tool, and it is a wonderful experience. And I've been privileged to see a lot of people go through this process. But too many times often I found is that interventionists will use kind of tough love and ultimatums under the guise of an intervention. Get to their heart. Each and every one of us has that within us. I can feel mine, it's beating quite rapidly. So I really, that's something that I think is, very, very, very important. Compassion, love, tolerance. Those that are in recovery have the benefit and the blessing to know what that is. So another scenario would be a family member's loved one works for the ABC airline. The employee is reaching out to the AP about their loved one who works for the company. The employee is a great employee, but when their work is finished for the day, he or she is struggling with substance abuse or alcoholism or polysubstance. So when they're at home or after work, it really is kind of affecting them. The AP can provide information to the family members to help the patient enter into treatment through an intervention process. Some of the myths about intervention. Myth number one, an employee's family member is not willing to enter into treatment. There's nothing you can do until they hit rock bottom. How many people have heard that phrase or that saying, rock bottom? So mentally, emotionally, physically, financially, eventually, and death, right? Which sometimes I see that too. That's really the mindset. Well, that's false. Let us step back, let us shape, let us mold, let us create a bottom that is tangible. Everyone's bottom is different, as I alluded to, mentally, emotionally, physically, financially. So, at the end of the day, yes, we all have boundaries in life. I don't like doing interventions to motivate the patient to go to treatment, kind of the big brother scenario. Well, ABC Airlines is going to, you're under investigation and and so you're going to lose your job. So it's really false. You don't have to wait. You don't have to wait for the employee to be suspended. You don't have to wait for the employee to lose that job. Let's raise the bottom in a loving, compassionate, caring manner. And I'm Irish, so I know stubborn. More than sometimes I like to admit. One of the other myths, myth number two, if you will, is myths about recovery. Some people believe that you can enter into rehab and finish 30 days and then you're magically cured. That's false. The difference between rehab and treatment is rehab is an in and out process, and treatment is a lifelong process. And just to segue into that, behavioral health does a wonderful job. I've had the privilege in 15 years to work with 250 different treatment centers, from building them to working in them to facilitating patients to treatment centers. And independently, if I had a loved one, that's where they'd go. There's three things I don't deviate when it comes to, can you all hear me? When I work with the families is two, financially, can the family afford it? Two, would I put my loved one in that treatment center? And first and foremost, which is it clinically appropriate? And 9 times out of 10, I can tell you that behavioral health at the Palm Beaches, it meets that criteria. So that's some of the myths, Well, I went to rehab and I'm all better. To my knowledge, there's no magical pill that you can take. Treatment, therapy, accountability, responsibility is what I see works. And they do that very, very well there. Some of the benefits of behavioral health at the Palm Beaches and interventions. Interventionists need to be able to work with treatment center in order to help patients seek long-term treatment versus short-term, as I alluded to. Through working with Behavioral Health at the Palm Beaches treatment team to create a practical application of involving the entire process of the family members, employers, therapists, clinicians, it can help patients that have gone through an intervention process support the long-term sobriety versus short-term. Practical application. I've seen this work. That's why I'm so excited about not just what I do, but a treatment center that said, you know what? Wow, that's great. Let's add tools to our toolbox to help that resistant patient, or somewhat, well, I'll go, to really engage in treatment. And that's from family members and employers and the treatment providers to reach out, because it's not the individual that we deal with. It's not. I'm not up against, you're not up against that person. I know what I'm up against. I'm up against the disease of addiction that kills over 8.2 million Americans each year, directly or indirectly. But that's what we're up against. And if you can get a mother, if you can get an employer, if you can get whoever's in the way of the disease of addiction to understand that, I'm not up against that person. I'm up against addiction. So one of the things that that I see also is that excuse me, and I apologize. With behavioral health at Palm Beaches, they really kind of go the extra mile. Treatment centers, employers, I deal primarily with people that do not want help at all. And with that being said, you put a patient into a treatment center, and through the years I've seen where, gosh, he's just too resistant. He's not willing to engage. What do we do? Comes back to the employer, they go through, he's suspended, or they just lose their employment, or the family member, does the things that happen in these bottoms. But I'll just tell you that I've worked indirectly with behavioral health for 7 years, almost 7 years. And I've been really, really privileged and honored to really have them say, what can we do better? How can we do it better? Intervention patients, as I said, not to be redundant, are very resistant by nature. I'm very empathetic when it comes to providers, because I've been on both sides of the fence, so to speak, from the patient's standpoint, from the treatment provider, the employer. But one of the little tools, HIPAA. How many people are familiar with HIPAA forms? Pretty much everybody, yeah? And that's a Federal Privacy Act that was created to help people get help when they wanted it, but were able to keep that confidentiality intact. And I'll just allude a little bit about that. Treatment centers would say, sorry, Mrs. Smith, if they could talk to Mrs. Smith, the mom, right, or ABC Airlines, he left treatment. Or he's just too resistant, he's just not ready, right? And then off they go. But as an interventionist, what I saw is, what if you were able to get an organization, a treatment center, treatment provider to really help you? That's a tool. It's not a hindrance. It's an opportunity for a provider, for a treatment center, and for the interventionist on ground zero to say, once you've built that bond, you've done the intervention, you get the patient to sign a release. You have some time. Normally, I fly all over the country, and so they might be resistant right after the intervention. Yes, I'll go. 9 times out of 10, as I said, it's a loving, caring process. And you build that bond right there. From the time the bags are packed, we get to the airlines, we get on the plane, and you kind of build a little bit of rapport. And get that signed. So it helps people, individuals, patients, from going AMA, against medical advice. The people that are trying to save their lives, right? And behavioral health of the Palm Beaches, I had that idea, and I said, I know it'll work. I know it'll work. Because I had seen too many times that very thing. Sorry, right? So that's just one of the things that, I see a difference in. And I'm an independent company. I built it from the ground up. I built it with things like this. How could we overcome that? And so the therapist, the clinician teams, they can pick up the phone, and maybe he or she hasn't signed the family or the employer, but of all people, guess who? The interventionist. So the clinician team can say, listen, Kevin, Paul is really just kind of acting out. I just want to kind of keep you in the loop and be the vessel, but also in going back to the bottoms. We talk about bottoms, right? And so versus, kind of kicking them out or asking them to leave because they're resistant, or to pick up the phone and really use this tool. And that's something that is, again, practical application I've seen work. Where the person didn't want to stay, they reached out, they couldn't maybe speak to the employer or the family members, but they called me, and we were able to really sometimes go to those bottoms, because in an intervention process, in what I try to do is really get to their heart. But the disease of addiction, 10, 20 days in treatment, rears its ugly head. What I was alluding to, which is we're not up against the person, we're up against this disease. And so that disease pops up in 30 days, and I feel great. I'm ready to go back to the airlines, right? And the therapist says, wait, you know, we haven't covered a couple other issues. Well, I feel better. Well, that's the disease of addiction. It's telling the brain to go left. That's what got them right here, right? So another tool in the toolbox, break glass in case of emergency, is look in the file. Say, oh, we've got one release. Who is that? That's the interventionist. Huh. What insight can he bring to the table, right? And yes, there's that bottom I speak about. Sometimes they have to hear it. I don't want, and they should not, in my professional opinion, be motivated by that. By what? By you're going to lose your job, your family won't talk to you. None of those things, tough love and ultimatums don't work. They really don't, guys. But what does work is boundaries, boundaries. Just like when I get it in my heart, get it in my head about addiction versus the person, boundaries. I have a boundary. But kind of getting off track, but in this process, and what I've found and that it works is that the call will come to me. I'd rather then go to, yes, those healthy boundaries of, you have to understand one thing, Paul, is that your family is unwilling to A, B, C until you stay or complete treatment. So the therapist, the clinician team, you know, goes to those boundaries when they want to leave treatment prematurely. But I'd rather have it there where clinicians and therapists and a treatment team and really the campus in which they're involved in, the community, so to speak, because if they're going to act out, that's where we want them to act out. That's where I want them to act out. I want them to act out with the professionals, with the therapists, the clinicians, the counselors. And again, not to be redundant, behavioral health does a great job. You know, I just, I can't tell you, as I said, I don't want to be redundant, but I've used a lot of treatment centers, and there's been a handful that get it. They get it. You know, rehab is rehab, and treatment is a lifelong process. And I hope that we'll learn, you know, about this disease, and one day we will be able to win that war. But I know that if we really do some of the things I've alluded to, you're going to win back one family, you're going to win back one company, you're going to win back, you know, educate EAPs that are on the ground, that are in front, you know, the front lines. And that's what's really this is about. So again, and I've seen it work. I've seen it work just last week. And I got a note on when I was somewhere in the country, and they said, you know, kind of, we're in that part where the brain is wanting to tell the patient to leave. And, you know, the patient's not real fond of their family right now because they loved them and tried to offer them the gift of recovery. But the treatment team did what they needed to do. And you know what? The patient stayed in treatment. So, because I've had the flip side of that, and the learning curve for me, everyone, was about 7 years ago, and I was facilitating a intervention company I was privileged to work for. It was a very big outfit. It had gotten very big, and it was a blessing. We were helping a lot of people. But the interventionist had done the intervention. The intervention was not successful. The interventionist went back to the home state in which they live and work in, and they called me. And they said, I didn't get the patient. I said, why are you calling me now? You have a whole team. You should have called me before you left that state, right? Because the families and employers, people don't know. They don't understand. About a month later, I got a call, and that call was, it was very sad. It was a mom. Moms are near and dear to my heart. I don't know how many mothers are in the, you know, but they gave us birth. But she called me and she said, I'm really sorry, Kevin, but I just wanted to inform you, my My son didn't make it. He drove down the country road that was in great state of Texas, if anybody's from Texas, and he was making a left-hand turn. He'd only had a 12-pack that day, but the bottom line is that he died at the end of his driveway. And this is someone that said, I don't need that, you know, and the interventionists bought into it. They bought into it. They didn't pick up the phone and said, I'm stuck. You know, my colleagues, I need help. Is there anything you guys can think of, right? So I brought everybody in from across the country, and I told them that story. You know, not to shame or blame, but, you know, people die every day. People die every day. And if you don't do everything you can, that's what happens. So that's part of the little tools and the little things that I've seen in this field, and why I created this company, Katie Consulting and Lifeline Intervention. So kind of how to evaluate interventionists. There's 3 national credentialing boards that really kind of govern an interventionist. Interventionists should have credentials. Make sure that the interventionist board's certified. NADAC, AIS, these are 2 of the 3 big ones. I belong to all 3 of them, and I'm very, very passionate about continuing education for interventionists. You know, it's great. It's 8,000 people now. They're doing what we do, but you know, you need a lot, and you'll learn, you know, hopefully till the day you die. But they should be certified through one of the credentialing boards, and you can Google it now. There's so much instant access to information. The Association of Intervention Specialists, as I was alluding to, and the National Drug and Alcohol Association of Interventionists. Check their level of experience. How long have you been doing it? I've been in the field for 15 years. I don't believe in percentages. I'll tell you exactly what I do. And that's 720 interventions, and I've been so privileged to do those. And I've missed a dozen times. Not getting them into treatment. I don't, you know, again, with behavioral health, they're great because they believe in education. One of the founders of behavioral health, you know, I remember when I first met him, and he said he was just very passionate about education and the disease of addiction. And so one of the other things you want to check is check to see their success rate getting, you know, patients into treatment. Again, some people will tell you percentages. I'm kind of I want to touch, feel, I want to know. And then, as I alluded to, make sure they understand different modalities of intervention process. It's wonderful because, as I again alluded to, you can Google information such as, you know, interventionist and different forms of interventions, different models of interventions. As I alluded to, there's systemic, there's invitational, there's the Gorski model, there's the Johnson model. And really, Dr. Vernon Johnson, who created this specific model to really break the cycle of there's nothing you can do until they hit a bottom, really takes the best from all of those. And those are really an offshoot of that primary one. So, talk a little bit about cost. Interventions costs can range from about $2,500 to $5,000. Some interventionists will work with families to help financial costs depending on the interventionist of services that are provided. But that's really kind of a benchmark that you look for. So again, there's I was talking with Mr. Shea, and he said, you know, I called one time and they wanted $5,000, and you know, that's okay. You know, I talk to a lot of families and mothers through the country, so my service fee is not that. My service fee is a little less than that, and we all have to make a living, but I do it because 9 times out of 10, when you deal with addiction, they've burned a lot of people out. They burn their employers, they burn their family, they burn their pocketbooks. So that's something that's very important. If they're commanding those kinds of fees, which is about in line, you want to make sure that they have those credentials. You want to make sure that they have the experience. You want to make sure that they really kind of know what they're doing, because you get one shot. You really get one shot to do this effectively. So now is the part of the demonstration. What you're going to see today is the demonstration of a Johnson model intervention process. I'm going to kind of set the tone of this and explain. Carrie, hi Carrie. Hi Mom. Hi, Tanya is going to play the favorite aunt. And just a note on Tanya, about the whole process, about how to break the cycle of rehab and treatment. She does a great job. I got a letter about a month ago from a family that I was privileged to work with. They went to behavioral health at Palm Beaches, and they didn't talk about their loved one in treatment. They talked about what they got out of it as a family, helping bring change one family at a time. And so she really, I just was very impressed with that. You know, that's just one more day where I just go, wow, that's a great, great organization. So, great job. All right, so want to come on up? Just before Josh enters the room, this is a home. And so Josh is going to be coming into the house, so we're going to take it from there. During an intervention process, Dr. Vernon Johnson's model, what you do is in your assessment, you get your assessment, you really kind of get the mechanics, the background about the family. So you do a pre-rehearsal intervention meeting the day before where you meet the families in person, where you've gotten some of the history via the assessment, but now you're with the family. You know, the aunt, who I know is very concerned, she's very close to her sister's son, and you know, mom who's just frustrated, and you know, it's really distracting her at the airlines because part of her brain is thinking about her son. And of course, some of the triggers and some of the behaviors, because patients, as I alluded to, have anger, denial, placating, manipulating, guilt, shame, remorse. You know, the job of the interventionist is to keep it cohesive. There's a letter format in the Johnson model that is really specific to that, and it helps kind of, break that down to the ability to communicate to the person and not the disease. So you're going to kind of see an insight into that today. Okay. All right. We ready? All right, great. So we've done the rehearsal meeting. This is the next day. We're going to do it early in the morning, so it's about this time in the morning. The reason why we do them 9 times out of 10, sorry, Josh, hold on. Early is because of the fact you want to talk to the person versus the disease. You know, at 8 o'clock at night, bottle of scotch or, bag of heroin or whatever. You're talking to the disease. So that's where families really make kind of the mistake. So it's about 8:30, 9 o'clock in the morning, and he's going to be coming in. Okay. If I don't fall off the stage. Hey, good morning. Josh, my name's Kevin Dixon, and I'm here on behalf of your family, and they have some things they need to tell you, and what I'd ask is that you just listen. When we're done, I'll answer all your questions.
Well, listen, I appreciate, I know what you guys are doing. I appreciate what you guys are doing, but, I'm not going anywhere. I'm not going anywhere. This is my home. I'm not leaving my home.
Okay, I understand that, and no one's really asking you to go anywhere right now. What I'd ask is that you just listen. When we're done, Josh, I'll answer all your questions, okay? All right, go on in and have a seat. Yes? We can't hear me?
We're going to speak up much louder than we would normally, so.
Sorry, I talk very softly until I don't have to. So on those days I'm not in intervention, I'm like, hi, nice to meet you. So I apologize, everyone. Okay. So just to stop right there, just so you didn't hear this, what Josh did was really? Wow. Okay. What he did was he tried to really kind of put that wall up right away. So it was basically, hey, what's going on? Right? So he kind of has an idea something's going on. So he's kind of a little bit respectful. But as you heard or may not have heard, hey, I know what this is, and I'm not going, right? So it's important at that pivotal moment, because 9 times out of 10, if you can't get them to really just de-escalate, right? Because they're already a little defensive. You know, they can do the 180. I'll come back to my house when you're not here. Well, I'm not leaving. Hence why I'm Irish. Over and above my degree in addictive disorders, I know that the disease of addiction does not stop. And so I'm not going to stop until we get resolution, one way or another, at the end of the day. So again, that's what Josh was kind of doing. So I'm not going anywhere, and I don't need this. And basically the interventionist then, you know, has the ability, or should have the ability, to say, okay, no one's asking you to go anywhere. I'm just asking you that you listen. So that's where we're at. Okay. So, as I said, Josh, your family's here and they're very concerned for you. They love you a great deal. And again, what I'd ask is that you just listen, okay?
Okay.
All right. Go on ahead.
Dear Josh, you have always been the most favorite nephew. Because I couldn't have any children of my own, I loved you like you were my own son. I have watched you grow up and never missed an important bit in your life. I loved watching you play hockey and would be there at every game cheering you on. You were an amazing player. I cherished our talks about your goals, life, friends, and God. I always felt that you were an old soul with such wisdom for your age. I hold close the memories of when your uncle passed away and you just showed up. There was nothing you could do, but you were there just in case I needed something. You fielded phone calls and helped take care of the house and yard. I don't know what I would have done without you and your mother. I remember when you decided to plan a surprise birthday party for your mom and asked me for help. We were like partners in crime, sneaking around and laughing about our stories to cover up our footprints. I will never forget the joy in your eyes when your mother walked into that room and started crying from the love she saw. You love your mother so much. As I remember you in this way, it is just that, a memory. In the past couple of years, this disease has taken away the Josh I knew. I never see you because you're locked up in your room, and when I do, you're mean and rude. And not only that, you look like you're not even there, like a shell. I have seen you get farther and farther away from God, and you appear to be void of any faith. This is not the young man I knew. I didn't realize how sick you were until you stole my piece of jewelry that I had from your uncle. The Josh I knew would have never done that in a million years because you knew how important that ring was to me. I thought seeing me in pain was your bottom, but I was wrong. This disease wanted you dead. You have caused so much fear and pain to your mother. She calls me crying on a regular basis, not knowing where you are or if you're even alive. And then when she found you that terrible day, unconscious, with a needle in your arm, I thought she was going to lose it too. I love you so much that I would do anything to help you. But I will not love you to death. I can't lose another man in my life. Please accept this gift that Mr. Dixon is offering you to give back your life that the disease has taken away. I love you, Aunt Tanya.
I'm telling you, I appreciate the letter, and I'm not going anywhere. You know, and for you, out of all people, to tell me that, I've seen you drunk 4 times last week alone.
Josh, it's not about her today. It's about you, okay? Josh, I'm going to tell you something. What they're talking about today is they're talking about that they love you, that they don't get the ability to anesthetize their feelings and emotions. Yes, you've seen your